Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage these risks. My name is Dr. Lucy Gibbard, and today we're very lucky to have as our guest Dr. Sam Murton, who's among her many roles, is the chairperson of the Council of Medical Colleges, who's going to talk to us a little bit about the council and its role in the medical landscape and what they do to improve the health system for clinicians and patients. So hello, Sam. Thanks very much for coming.
Yeah, sure.
We also have the old crew here. Many of you will be familiar with. We've got Dr. Sam King, who's
not that old.
Not that old,
Lucy,
okay.
Yeah.
A medical legal consultant with MPS. Hi, Sam.
Hey, Lucy.
And Dr. Tim Cookson, who is a medical legal consultant who's recently retired from MPS and is no doubt now filling his time with much more exciting things. Hi, Tim.
Hello, and I echo the old.
Oh, right.
Thank you, Lucy.
So, Sam, I thought we'd start just by hearing a bit about how the Council of Medical Colleges started and what it does, because I think actually a lot of clinicians out in the New Zealand don't actually necessarily know what it is or what it does.
One of those mystical organisations.
It is a mystical organisation.
Yeah, sure.
Tell us what it does.
Yeah, so Council of Medical Colleges represents 18 colleges. Some of them are New Zealand only and some of them are Australasian, so it covers both. And there's 9,000 medical practitioners or doctors in New Zealand, so that's who we represent from our college's perspective. And as medical colleges, we are educational bodies responsible for training, examinations, reaccreditation and certification of our medical practitioners. And also a lot of colleges and societies set the standards for what that particular area of medical practice is. And it was set up in 2001 to enable all the member colleges to get together and discuss issues, and so that we weren't sort of like all hearing different bits, but we could all hear it together. So, and we have a sister organisation in Australia, which is the Council of Presidents of the Medical Colleges, slightly more hierarchical than ours. And so we are trying to help inform them on how to make it a bit more collaborative. Yeah.
Brilliant. Yeah. Very good. There's New Zealand teaching Australia something. That's interesting, and it's relatively young compared to actually how old the colleges are then.
Yeah, it is relatively young, and I think it was brought together because there was just a need to get the colleges hearing from all stakeholders and hearing the sort of like the commonalities that we all deal with every day and hearing it together so that we could think about how we work together to make the changes.
I think the good thing is that you have a stronger voice. That's for example, when you're speaking to the government or the Ministry of Health, you've got a stronger voice when you say, actually, this is the combined colleges. This isn't just general practice or, the surgeons. Yeah. So it's fantastic.
Yeah. And I think we have become very cohesive over the last probably 2 or 3 years. It's not that we weren't before, but we've actually got more solid in the last few years. And partly that's been driven by the way we've changed the makeup of the governance structure, but also how we've changed the strategy for how we work together. Yeah. Yeah.
So tell us a bit about that. How have you changed the governance structure?
Well, so we've been a council, so it was very flat, and there was a council that had every college there, and then also every college would bring their CEO or their executive director. So from New Zealand, there's the New Zealand bosses, and then also the New Zealand medical lead for that particular college, and then so the College of Surgeons or College of Physicians. And we only do this, the main colleges. We don't do, like, if you think physicians, there's pediatrics and orthopedics or pediatrics and respiratory and cardiology all underneath, but we have the College of Physicians as the lead organisation. So we have the New Zealand representatives for each of those colleges. We had them all as a council. So at the time there was 16, so 32 people there. They all had responsibility for what went on. We all pay a fee from a college perspective to be part of the organisation. And in governance structure, we were therefore all responsible for making sure the money worked and everything else. So we got a little executive that made sure the money worked. But then it still meant that everyone was responsible. So about 2 or 3 years ago, we changed it to a board. And so the exec team became the board, and then the council became the council. So they were our representatives, told us everything we needed to do, and had all the discussions and all that sort of stuff. And the board just made sure that we met the strategy, and we could put policies down, and that we made the money work and gave them a budget to work to. So it meant that the people who were really responsible for making sure the whole business worked were a small number, and the people who were responsible for making sure that the voice was heard were the large number.
And I noticed on your website, when you took the list of who we are, not all the colleges are represented on that list, are they? It looked like.
On the board, they're not.
So I was just wondering, on the board, so are the colleges that are not on the board, is there any kind of sort of difficulty there that they don't have direct representation?
No, because the board's
council?
not a representative board. It's just it's a group of people who make sure that CMC works.
So they're governance,
so they're not making sure that their college is heard. They're just making sure that CMC does the job, and the council is where your voice is. And it is a hard thing to people to get their heads around, because the board sounds like the more important role, but the more board is actually the more boring role, in that you are just making sure the money machine works and the strategy happens. And then it is absolutely the voice of the council who are the voice. So we have, so our way that we do that is that from a council perspective, if we put out a statement, we have to have everybody agree or no one violently disagree. And we have a consensus so that the majority agrees to this, so we can put out a statement saying the majority agree to this. And if someone violently disagreed, we wouldn't even put out the statement.
That's really interesting. I was going to ask you about that, because if you think about I'm sure, quite strong personalities and strong opinions, and people are obviously representing their own specialty, there must be a lot of robust discussion.
Yeah, there is. But I think what we've done, we had a strategy meetings and worked out what it is that we wanted to do together. And the do together stuff is around workforce, it's around advocacy, it's around making sure that we have got a strategy for what we do, and it's about stakeholder engagement and collaboration. So our meetings have changed from our board meeting is only the night before and just talks about stuff that relates to, is the money working and are we meeting our strategy, and we got the right people coming to the meeting for the council to be able to talk to, and etc. And then and then the council day is often it's workshopped, often it's about stakeholders coming and saying, this is our conundrum, can you discuss it with us? So everyone's involved. So it, as far as the mechanism for making it work, is the other part of it as well. Yep.
It's interesting because I came along to one of your council meetings a few months ago with one of our lawyers to talk about the new medical aspects of fitness to drive and how that was going to affect all the different specialities. It was really interesting to see this room full of different specialities and hear all the different views that actually I hadn't really particularly considered how medical aspects of fitness to drive is going to affect the psychiatrists or, other specialities. And it was really interesting. And everyone heard each other's problems. I thought it was a really great environment to actually discuss issues that do affect us all.
Yeah, because we had a discussion a few months ago around laboratory stuff. And the College of Pathologists said, well, actually, the digital connection is really important. And you go like, why, you get the test. But actually what happens is often because they have now very specialised, which we don't know as a college of GPs or no one else knows unless you are in the college, you might have someone who's very specialised in a certain area of pathology or histology, and they get sent all the stuff. So, like some of I know some of my tests go to Christchurch, but often they'll get to send all the stuff and they have no ability to look at the patient information on a hospital, combined platform. So for them, the digital divide is hugely problematic and we don't even think about that.
No.
So when you're solving a digital issue, there's, like you say, there's different issues for every college. Yeah.
I'm quite interested to know how much sway the Council of Medical Colleges have, say with the Ministry of Health, with Te Whatu Ora. Can you just talk a little bit about that?
I'd like to say huge. But I think we are seen as a very important body. We have had some consultation documents that have only come to us because we are the combined colleges. And we are the combined colleges with a vested interest in making sure that training works and standards work. We're not actually about the employment or any other issues. We're about making sure that patients get what they need from a perspective of what we do in the community. So we are seen as a very critical voice, and critical in that we can critique, but also that we can have an important voice that is spread across all the colleges, and you hear from everybody's perspective. So what we have done is we have although at the meetings, which are quarterly, we have our head of New Zealand for each college and our executive director. We also have a policy group that gets together. So all the policy, I can't call them the policy people. It's another word that sometimes we use. All the policy people from the colleges often will get together as well quarterly at separate times and talk about combined submissions about a particular thing. So we will sometimes, and we've made it really easy for them to connect, and they are also they do chat now with each other around what they're doing for their policy documents. And because we often have key elements that are across all colleges, then when that comes up, that gives us power, because every college says this is the critical issue. And so then Te Whatu Ora or the Ministry of Health go, oh, okay, yeah, that's critical for everybody. So things change.
I noticed in your brief, one of the things you talked about was workforce issues. And obviously there are other organisations involved with workforce issues as well, like ASMS. How do you work with them in those areas?
Yeah, so we do. One of our stakeholder relationships is with the unions. We also have a relationship with the Medical Council. We talk with the Nursing Council on and off as well, and they'll come to meetings too if there's something that's a combined critical element for us. I think workforce-wise, we have, there was a workforce department in the ministry, and with Te Whatu Ora, we've had lots of conversations with those people, have workshopped some stuff as well. But it's always that conundrum of, what do we need as a workforce? And no one's ever solved that problem. And it would be nice to be able to sort of have some pragmatic idea of what you think workforce should be. The thing that we have done over the last couple of years is worked on our cultural safety. So we worked with, so that's a combined workforce issue, is that everyone needs some cultural safety. And although we didn't want to be called old dogs in this room, some of us didn't get the opportunity to learn about cultural safety in our training at medical school, and dealing with different cultures. And how do you make them feel safe coming to see you who has a different worldview? And so we have worked over the last we started off by doing an audit of all of our colleges, probably 3 or 4 years ago, to see where we were at with especially Māori and Indigenous health in our colleges, and found that we were rather lacking as far as all colleges go. Must say that college GPs were seen to be the head of the game, but still had a lot of work to be done. And so then between Te Ora, the Māori Doctors Organisation, and us, the Council of Medical Colleges, we put together a document and looked at we did a literature review. There was nothing in there. We put money into making sure we had good researchers involved. And then we worked on a framework for vocational education for cultural safety training. And then we have now worked, and then we've put in place, we've had a ropu, which is a group of our educators for all of our colleges, running every 6 weeks for 2 years, getting our colleges learning how they can put this framework for cultural safety training, whatever culture, into their own curricula and into their own organisations. And we're about to do another review of all colleges to see how the movement has gone from 4 or 5 years ago to how it's changed to now. And that has been a huge investment from the Council of Medical Colleges. It's been a huge investment from every college on what they've done and how they've shifted it forward. And we have another Cultural Safety Day in a couple of months' time, which is going to be sort of like our, we've invested all this time and effort, and now it's off you go, colleges, fledge and start running with it and doing your own thing. The document on the framework for vocational training was the first in the world. So that was really interesting. And Australia is using that as a framework for themselves and have put something together for Aboriginal and Torres Strait Islanders, and are looking at how they look after their Indigenous populations and what they do for that, but also for anyone, especially when you're in a world like us or in a country like us where you have, a wonderful mix of ethnicities and groups and all those sorts of things. Some are in the minority and really struggle, and some are in the majority and have a worldview that is, this is the landscape that we do, how we do things. And I know that speaking personally, when we started doing this, and there was a document that came out in the Medical Journal, and it's New Zealand Medical Journal, saying that we all prescribe contraception differently for different people. And I was like, no, I don't. And sure enough, looking through my data and my stats, there was exactly that difference. And so then I talked to some of my Pacifica women, and I talked to some of my Māori women, and we looked at through my data and what we were recording and what we were asking and how we ask stuff. And it's all those things are about cultural safety. So if you're talking to a woman who's Indian and you're saying, what do you want for contraception? Your first conversation is, do you want to go on the pill? No, that's my worldview, because the pill's easy and I could do it, whereas it may not be what they want at all. And you need to think about that. Yeah,
that's really interesting. I have had some cases where international medical graduates come, and they might have provisional vocational registration, for example, and depending on which country they've come from, it can be very difficult to assimilate into the New Zealand culture, the cultural mix that we are. So are the colleges, do they have a program for that, for those people, for the international medical graduates, to help them? Because it's huge, and I don't think it's something you can learn overnight. You can't just do a 2-hour video course and think you've kind of achieved it.
And it is that balancing act, isn't it, between what's enough learning?
Yes.
So a lot of our colleges have been accused for years. One of our meetings was, we are seen to be patch protectionists. So what are we doing about that? We're charged with the sort of, you're from overseas, we don't like you brush. And that's what we get accused of all the time. And I've challenged our colleges and said, well, this is the rhetoric about us. What are we doing to change this? But you still have to have, if I went and worked in America, or if I went and worked in China, I would have to learn how Chinese medicine worked, and I would want to be confident that there was someone helping me to learn that, but also that I had enough time to learn that so that when I got my trainer wheels, I was fine. But at some stage I'd go, yes, you have medical knowledge, and now you have some knowledge of how the landscape works and the context that you're in, and now you can go and do. And we need to get to that phase for many of our colleges, and they are working on that. And it's been forced upon us in Australia by the way things are heading, and that they've taken a lot of the credentialing away from colleges. They've sort of said, "Oh, you're good enough." It is a little bit fraught. I mean, I think years ago we would have international doctors come in, or even any health professionals who may not have the qualification that we expect that they have, and may end up working in a small town. And if you've got the business credentialing them to say, yes, they're good enough to do the job, and that has turned to custard for a few people. And it's a matter of what's your risk appetite, because turn to custard when you're dealing with people's lives or doing an operation can be deadly. So we need to think about what's that high risk for our internationals coming in, and what's a safe enough training for them to learn the context of New Zealand.
It's really interesting, isn't it? That whole patch protection argument. And I was going to ask you about that with the role of the council in deciding where that level sits between maintaining safety and standards versus actually allowing a workforce in that may have different standards, be they better or worse, they're different. And actually, how do we apply that? Because that must be across all the colleges that they have that issue. There are workforce shortages in lots of different areas in New Zealand.
Yeah. And New Zealand has the highest international medical graduates in the OECD. So we've got 41% across the board. And Medical Council credential nearly 1,500 overseas graduates every year and 500 graduates from New Zealand. So the 1,500 are not graduates, they're doctors coming in, but they are often highly skilled. 60% of them only stay for 2 years. So there's this huge rolling wall of credentialing and training. It's like taking on new patients, they come in and out all the time.
Yeah.
And so, and that's okay. But what we do need to get to is not the not tarring everybody with the sort of come in and out brush. Like you're going to come here for a couple of years and then you're going to go away again. So what we need to be able to do is say, you've got really good supervision. There's some courses that you do, which isn't just a couple of weeks. It's like cultural safety training of some sort, and there are some options that are available, and each college can say this is selection. Have a look at those. What's your mentoring supervision like? I think the biggest issue that we have is that a lot of the colleges have, and because they're Australasian, and in New Zealand you're beholden to your Australasian bosses about how the rules are set, that when you comes to can you be a trainer, the international medical graduates have had the door shut. And so what we're trying to do is say, well, actually, you have learnt your craft. You know how to train someone to do an appendix or to do a tibial nail or to do whatever else it is as far as the skill set goes. Just because you didn't train in our own training environment, it doesn't mean that you can't train the next person for those particular skills. So we are trying to lever our colleges into going, just be a little bit more open to overseas trained people being able to train here. Yeah.
And following up on that patch protection sort of thing, I think there is a perception out there that the colleges limit the number of people who go through a training program in order to ensure that they have sufficient
of course
work,
they do
which seems a bit weird given that people are crying out for operations or whatever.
Yeah.
Can you make any comment on that?
Yeah, so what's our control? How do we say, no, we're only allowed 5? No, I think from every college's perspective, if you think about it clearly, the more members, the better. So membership of college is an absolute driver for any college. But the constraint is the number of training places available. And the training places available are constrained by the number of seniors, and this isn't even an international medical graduate, seniors who are available to provide a adequate training site. So that means that you've got a roster that's reasonable, that you've got the right people in those rosters. I think we do need to think a little bit more laterally around for New Zealand. Like if you're on your vocational training from start zero going through, for rural hospital medicine, you have a variety of seniors who are helping you to learn your craft. And I think from a lot of colleges' perspective, it's you can only have your own seniors. So you can only have orthopedics, or you can only have ED, or you can only have, and we need to be a little bit more flexible around that. But then the other part of it is that we are constrained by Australia. Australia will say there's this many trainees. And if in New Zealand you want plastic surgeons and 11 of them are Australian and we need 5 here, we don't get 5. We might get 1.
Maybe we need to cut that cord.
Well, we've had a conversation with one college to talk about cutting that cord. It will be interesting to see how the relationship goes with this changes that Australia are making and what the impact that has for New Zealand. But, in New Zealand, we have a public health college. We've got the College of GPs, which is separate from the College of GPs in Australia. We have other, I think there's sports and exercise medicine, which has an Australian equivalent. There's musculoskeletal medicine here. We have urgent care here, which we don't have in Australia. And some of that is birthed out of ACC, because ACC had, like very specific roles that they were funding. So therefore those specific roles became a craft group. And so then they became a college. Yeah.
Interesting. I was actually going to ask about how colleges get born, because 18 seems quite a lot.
Yeah.
And so if you get together with a group and say, we have this new scope of practice, they can just become a college, can they? Is that?
Well, I think medical councils got to the sort of point of going like, enough is enough. There's 36 of us, 36 craft groups.
Right.
Yeah. So, and we've got the sexual and reproductive health was probably the last cab off the rank. And that's because there's a lot of community-based sexual and reproductive health that's is a conglomeration of a whole range of things. So it's about infectious diseases. It's about gynae and women's health, but it's also a bit of urology and men's health stuff as well. And then there's a bit of general practice side of it. So it actually was a very large area of medical expertise from a range of different current colleges. So therefore, no current college said, yes, you're totally with us, because if it's with gynae, it's not all gynae. It's hard to make it fit. So in that respect, it was logical in some ways to have it as a separate college, because it brought together so many different parts of the various colleges. Yeah.
Can we just move on and talk a little bit about I know in the Honourable Simeon Brown's recent discussion document about putting patients first, he talked about the credentialing and accreditation and that perhaps moving to councils. Currently that rests with colleges. Have you got any comment around that and how the colleges feel about that?
Yeah, so from the Council of Medical Colleges perspective, I think it's probably the first time that we've had other times that all 18 of us have said no. We combined wrote to the Ministry of Health and said that the document had some very leading questions. And I think one of our concerns was it sort of said it got couched as putting safety first, but then it talked about taking regulations away and making them looser. And most of us would go, well, actually, safety means that you've got some really good defined rules that mean people understand what safety means. And it's like, barriers on bridges and roads. It's like there is a barrier there so you don't cross the median line. There's rules on how to drive so that you actually drive safely. So there's a level of regulation that we see is an expectation that keeps the general everybody safe. In some ways, some of the commentary in the document was actually releasing some of those regulations. Some of the commentary in the document said stuff that actually isn't currently true. So Medical Council currently has 12 members. 8 of them have government agreement on their appointment, and 4 of them are from member voting. There are consumer representatives on the Medical Council, so that as far as the makeup of our current Medical Council, which isn't decided by the board, it's decided by isn't decided by colleges, it's decided by 9,000 medical practitioners, and they don't care what their college hat is, they just care about who's the best person to represent all members of medical practitioners on the Medical Council. And then there are consumer reps on there as well. So currently, I don't know what more government influence we'd want on that, because currently it's 2/3 of them are government appointments or government sanctioned appointments. I think the other thing is that the actual document was quite had some leading questions, had sort of almost some preconceived ideas about what you could answer, and the questions were really hard to answer. And so we did make a suggestion to Ministry of Health. We said, look, these questions are leading and have some preconceived ideas, and also some of them just aren't accurate as far as the truth goes, and the ministry said that they couldn't change it. So the Council of Medical Colleges, all 18 of us, have put a document into the Ombudsman to say that consultation document wasn't a good decision-making, didn't meet the good decision-making standards. And so we're waiting to hear. We've got a case number with the Ombudsman waiting to hear back. Yeah.
Very interesting. So just to clarify, we're talking about the document consultation on regulation of practitioners in New Zealand, just in case, because we kind of started into that, and I just thought maybe people... Very, very interesting that that's the approach that the colleges as a group have taken.
Yeah. We have all submitted, and we've all submitted in various ways, and we've all, gone out to our membership and asked them to submit and asked all our individuals to submit as well. So there's a lot of voice that goes out there. It would be really interesting to see how many from the public submit because that's, this is meant to be a public consultation, and you'd really like to hope that the public would have an opinion, but also some of the questions may not be, you need to have some background knowledge to be able to answer the questions. And if you're asking a question where no one has any background knowledge, it actually makes it really hard for you to answer it in a way that might be accurate or whatever. So.
Yeah, and I think some of the starts of the questions and the second half of the question combined two things that weren't necessarily, it was hard to say yes or no because they were two opposite things in the question.
I think if there was, if that included more background into the topics and the questions they were asking, it would be really helpful for the public. But I mean, if you work in the sector like we do, of course you understand immediately what they're asking and what they're talking about and have an opinion on it. But for the general public, it must be very difficult because they only see a snippet of the health sector, which is usually related to, I go and see my GP and I've been to the hospital once. So I think that was the disappointing part about that document, is one of the disappointments, really.
I think it is, with any document, if you're going to ask someone a question, you need to give them as much information as they need to be able to answer that question. And I think part of the problem with the document is that you are asking questions of people who didn't have enough, like you say, of a preamble to read or a background knowledge to understand what the question was meaning. Yeah.
So moving on, the other thing that's been in the news recently, and I'm not sure when this podcast is actually going to come out, but is the physician associates being regulated and understanding that they're going to be under the medical council. Yeah. Is the colleges and the combined the Council of Medical Colleges had anything?
Yeah, we've been talking amongst ourselves for quite a while, I think, about physician associates and where we see, in the New Zealand landscape, where they might fit, and also from different perspectives from the different colleges. So like we were saying before, one college will have one opinion and another college will have a different opinion. So, for example, in radiology, there's a lot of opportunity to have someone who's got some medical background knowledge and some hands-on skill set to be involved in procedural radiology, say, because they're directly under supervision of someone all the time. They are doing a procedural, they're like an anaesthetic tech. They're doing stuff in supervision as a combined team-based approach that actually works quite well. And you may not need to have done all your medical training for 6 years and gone on to vocational training to do this particular skill set, which is fine. I think the thing about it is I think the biggest problem is unless you've trained in medicine and know all the knowledge that you need to know to get to the vocational end game that we're at, and especially in, say, general medicine or maybe general surgery, you're doing things across the board, or in general practice, which no one understands because it is mystical, and random things turn up completely every 15 minutes. There's something random that's turning up, and so the knowledge that you need to be able to deal with 15-minute random constantly is actually massive. And they did some research on the knowledge base and cognitive load of every profession, and because in general practice it's every 15 minutes that you're having to make this I suppose, uncertain magical leap to a conclusion, that cognitive load is highest of all the professions, because you've got the broadest length of knowledge at the highest depth with the most rapid change all the time. So then when you think about that, it's not that there are probably components that might be able to be done, but what we've seen in the UK is that there are people who've been left to be sole charge in an environment where it is the broadest scope of practice with the biggest depth, and they haven't had that training. So I think there's risk to our physician associates being left in isolation in any role that they do. I think when you think about uncertainty of what you're dealing with, that's actually a problem, and that's the biggest place uncertainty exists is in general practice. And in various other roles where there's a lot of uncertainty about what's turning up and what you're dealing with, and if you don't know what you don't know, then it's actually really hard to do without being really well supervised and having someone to check with all the time. So I think regulation didn't happen in the UK and is happening now. And so regulation, if you're going to start off with this, then regulation is probably the first step that you need to make. And then there's decision making around which areas of practice or clinical medicine are they really appropriate for. And none of us as highly trained professionals want to work in isolation anyway. And so
nobody does.
Nobody does. And
yeah.
So in that respect, then there is a supervision component. And in the minister's announcement was that physician associates need to be supervised by doctors. Where does that supervision time come from is the other question that we need to think about.
Will the Council of Medical Colleges work with the ministry in developing those scopes?
And I think it's like the standards and where we think and what the expectations are, and then also what the supervision requirements might be. And we'll work with Medical Council on that as well. But I think, we do have this sort of like, well, I'm an independent person, and you go, yeah, you are independent, but actually, like we was talking about before about patient safety, patients need to know who it is that they're dealing with, who's looking after them, and what skill set that person has, so that they can say, yes, I'm making an informed choice about my care. So if you had someone who could operate and you went to them and said, I need my knee done, but you didn't know whether that person was a person who'd done any knee surgery before, they might be the person who's done appendixes, you'd want to know.
Mm.
Yeah. And there's certainly risk with the current situation, because we've had a number of cases at MPS where doctors were supervising physician associates, and the physician associate has done something, but they weren't actually being directly supervised for that particular intervention. And of course, all the responsibility then falls on the medical practitioner rather than the physician associate under the current regime. So having some sort of regulation where there's at least some division of responsibility.
Yeah.
I think it'll be interesting to see. My assumption is that the Medical Council will produce a statement around the requirements for supervision. And it seems in primary care anyway that supervision is more fraught, because we tend to work one-on-one with our patients. We're relatively siloed. We're each in our room. And as you say, it's very difficult to find the time, because if you're going to closely supervise another colleague, then it means you're not seeing patients or as many patients. And so that becomes a difficulty. It would seem to me that in a hospital system, where they work in hierarchies anyway, that it might be better suited to the physician associate model. You think about how house officers are supervised. They're fairly closely supervised. And of course, they ask when they don't know, presumably, hopefully. And it seems like a better environment for physician associates, I would have thought, than primary care. Although having said that, currently there are 50 in New Zealand, and from the anecdotes I've heard of the few that have spoken up, the practices and the doctors seem very happy with the care the PAs are providing, but I guess we don't know the details of what supervision arrangements they've got, and whether the PAs see undifferentiated patients and all those sorts of things. So there's a lot to think about.
And because there's no training in New Zealand too, we're reliant on
not
overseas,
yet. No, that's right.
And they vary quite significantly from individual practice to practice. Yeah.
So coming back with the Council of Medical Colleges, what are you working on at the moment? Is there anything? What are your hot topics?
Yeah, so our hot topic at the minute is we are looking at the physician associate statement from all the colleges about, like what across all colleges, what do we believe? And so that's being worked on at the moment. And then also we have got our the HPCAA Act. We have put in our submission. We talked to our Ministry of Health middle of last year, and we have actually been proactive in trying to engage with the ministry on what's the next steps prior to this consultation document coming out. So because we'd had the one conversation in August last year and then we'd heard nothing. So we are really keen to be involved in working on that from a sort of, how do we make this work for the public? And like Sam said before, it's not like our focus is on ourselves completely. Our focus is on the craft that we are trained into and provide it safely to patients. So we think about patients all the time as far as what we're learning and doing. And then there's some work around our workforce and especially with what's going on in Australia and the specialist international medical graduates, looking at our own practices with international medical graduates and how we get them involved in training as well. And that's probably enough workload. We try and do a year's worth of work, and then whatever other advocacy comes our way. Yeah.
Really interesting. Very good. So look, this has been a rather broad conversation which has gone off in a few directions, but thanks really very much, Sam. It's been a really interesting for me to learn about what the Council of Medical Colleges actually does and the work that you're doing, and it sounds fascinating. Is there anything else anyone else wanted to add at the end, or anything else that...
No, I'm just very grateful
that
the Council of Medical Colleges exists. It sounds like it has significant influence, and not just within our profession, but also, in terms of government and how they work. And I'm sure it has an influence too on the Medical Council and how they view things. So thank you very much for the work you do.
Yeah, no trouble. I mean, we've got a really good relationship with Medical Council. It's been very strong the whole way through that I've been involved. And we also have very good relationships with all the stakeholders that we get involved with. So we are as embracing as we can be of anyone who's involved in trying to make sure that there is that combined voice going into any discussions that happen. Yeah.
So if a clinician, if one of our listeners has an issue that they think that your council should be looking at, would they go to their own college?
Yeah.
And you wouldn't get individuals coming directly to the Council of Medical Colleges. It feeds in via the individual colleges. Is that right?
Yeah, it does. If there's an issue, I mean, we can, as chair, you can write to the chair of the Council of Medical Colleges if it's an issue that you sort of think that all colleges should be thinking about. Interestingly, a few years ago, we were one of the places that we were the first to hear about that rapid silicosis condition. And so that was when that was first starting to come up, and they were looking at whether that, an engineered stone was a real problem. And so from all of our colleges' perspective, it's such a great place to come and say, alarm, there's something going on here. Everyone needs to be aware. That just goes out to all our members straight away. So it's a really good avenue for connecting with all health professionals. Yeah.
Excellent. Well, look, I'm sure we could talk for ages, but we are kind of running out of time. Look, for anyone who's interested, they can obviously go to your website and see what the Council of Medical Colleges does. So thank you to Sam King and Tim for joining me in the discussion, and a special thank you to Sam Murton, who, as a very busy lady, has kindly agreed to come and talk to us about the important work the Council does. And thank you also to our listeners. I hope you found this useful. If you enjoy our podcast, please subscribe and like them. If you have any suggestions for other podcasts or helpful feedback, please email us at nzpodcasts@medicalprotection.org. Thank you, everyone.
Thanks, Lucy.
Thanks, Lucy.